if you've made all of the lifestyle changes necessary to help slow down the progression of p.a.d. and you're still experiencing lifestyle limiting claudication, your vascular specialist may schedule you for what's called an angiogram. To walk you through what you can expect in the cath lab where these angiograms occur during this procedure, we have Dr. Mary Costantino, who practices in Oregon. Also, Dr. Michael Cumming is going to be joining from Rochester, Minnesota. But let's start with Dr. Costantino. Doctor, thank you so much for joining us.
Thank you. It's so great to see everybody and hear these stories. And nice to see you outside of the clinic where we usually see people. So this is fantastic.
So, let's start with, what are the questions patients should be asking their physician in deciding upon whether an angiogram really is that next best step for them, and go into some of the details of what even is an angiogram.
Yeah, so a lot of times, patients just they feel their foot or see their wound, and they don't really understand the piping system underneath within their leg. And so I equate arteries to like pipes. If they're blocked, they need to be opened in order to get the blood flow down to your foot to allow it to heal. So you can do all the wound care in the world, and that's certainly helpful to try to treat the skin layer, but you got to have blood flow headed towards that foot. So the very first thing to ask yourself when you have a wound is, what's your blood flow like? That usually can be answered with an ultrasound, which is simple, it's inexpensive, it doesn't require any needles. And you can usually get a pretty good picture of what's going on with an ultrasound. Now that's going to be performed to different levels depending on where you go. So some places are really just going to look at, mostly consider your thigh arteries. Most of the time they'll look at the arteries in your calf. And then usually people are you'll get what's called an ABI, which is where they put that blood pressure cuff around your ankle and around your arm, and they take the blood pressures. Those are really not the best tools. They're kind of all we had for a long time, and they're still indicated. But a lot of times patients are familiar with that blood pressure cuff test, and it gives us an idea of what's going on, but it's only part of the picture. So people who do not perform these procedures or operations really don't know how to put together the results of those blood pressure cuff test, which is called an ABI, the results of your ultrasound, and your clinical picture. You really need to have a specialist who's asking you, looking at all three of those things. The goal of what we do is limb salvage, amputation prevention. So our goal really is to keep feet attached and get wounds healed and get you back up and walking and moving. I usually start with the same thing Dr. Phillips was talking about, what's your motivation here? It is, kudos to all you patients who are dealing with foot pain and ulcers. It's very, very hard to sort of be stuck in a position where you can't walk and you can't heal. And it leads you to want to sit around and smoke cigarettes, because what else are you going to do? So my goal is always, getting arteries open and getting people out doing what they need to do. An angiogram, I'm seeing here comments, 4 hours. An angiogram usually takes about an hour, hour and a half. If you're very complicated, it can take 2.5 hours. Mike is going to show you a lab and talk to you more about what that looks like. I think one thing we're trying to figure out when we see you in clinic is, will an angiogram, an endovascular approach be better, or will a surgical approach be better? And I think you need to know, when you go to a doctor, you need to know that there is an endovascular approach. That means we're going inside the arteries, minimally invasive. Also a surgical approach with bypass. So what we don't want to have happen is you just being told about the bypass. Now, some people are better candidates for bypass, but you need to understand them both and why you are a best candidate for each of those pathways. They're very different procedures.
I think that's so important for them to really ask those questions, but to get multiple opinions from, someone who primarily does bypasses and someone who primarily does and endovascular to really understand, because it's so easy to get one opinion and your doctor to say, hey, we're going straight to an invasive procedure and you're the best candidate for this procedure and here's why. But then another doctor might have a different philosophy and a different reasoning as to why an endovascular approach might be best for you right away. So should we go and jump over to Dr. Cumming, and maybe you can help me work with Dr. Cumming to show us the basics of an angiogram and to show us the cath lab?
Sure, that would be great. Let me respond to that real quickly. Is that one thing that didn't occur to me that people might not understand? There are many types of people who do vascular work. Okay, so a vascular surgeon comes from the surgical world. So they're going to lean towards doing more surgeries. So if you hear you're not a candidate for endovascular, you're only a candidate for surgical bypass, and that person doesn't primarily do endovascular, that's not an adequate enough opinion. And that's what Kim is talking about. So you need to go to the person who predominantly does one way or the other and get everybody's opinion. And Kim is a great resource for those of us who are doing advanced critical limb arterial work. On the outside, the sticker on the wall, the plaque is all going to read the same to patients. And so you won't know, you won't be able to tell. But a vascular surgeon comes from the surgical. Interventional radiology comes, all we do is this. We don't do the surgeries. Interventional cardiology and other types, mostly just interventional cardiology, also don't do the surgical bypasses. But let's turn it over to Dr. Cumming. He's standing live in his cath lab in Minnesota, and is going to walk you through what to expect after he takes you from his unit where you have an IV in and walks you into the cath lab. Mike, do you want to start?
Yep, he needs to unmute.
Oh, can you hear me? I'm signed in, Kim, through my phone and laptop, so I'm good.
Perfect.
Great. So this is our interventional room. It's a very fancy piece of equipment. It's very intimidating sometimes for patients as you get wheeled in and you see these big imposing things coming over you. But so that's part of our idea is to give you a little bit of a look at what these rooms look like. So when you come in, it's not a terrifying experience. So this room is a state-of-the-art room. These rooms are really expensive. We're at least sitting in over $1 million of equipment here. So behind me, we have our large monitor that lets us see everything. And see if I can get it back to life. So it allows us to display information from the C-arm, which is this guy here, and we'll have a better look at that in two seconds. But also from our ultrasound machine, from our intravascular ultrasound machine, and other sources of information like vital signs and that. The C-arm is this big piece of equipment as we come over here. And so this is how we spend a lot of our time understanding what we're doing. And under the table, this is where the X-ray source comes from. That's what we call the X-ray tube. And this is the image detector. Up here, we call also the eye. So that sees the radiation that comes through, which then goes to a big room of computers and then shows up on our monitor here. So we can see what we're doing, where we're going, and what our devices are doing. This is an overview of our room. And I'll show you just a few of the toys or instruments that we use to do these procedures. The basics of everything we do is basically, hopefully I can get this projecting reasonably well so you guys can see. This is a catheter that we use. This is one of the fundamental things that we begin with. We have wires. Look this up because the wire is blue. Wires are come in all sorts of different shapes and sizes, and so we use them depending on the situation and what's required. A lot of the work we do is based on balloons, and so this here is a simple balloon catheter, and we can inflate. The balloons do not stay in. I often get asked that, but we can inflate the balloons where they come up, where we use contrast and to inflate them and then to deflate them.
Mike, can you talk about how that balloon actually gets in your artery? Like,
Right.
there's a balloon on a table. How does that?
So once we get to where we need to be using a guide wire, the balloons will travel over the guide wire like this, and I won't load it because these are mismatched, but the balloon will slide down the wire to where we want it, and then we inflate the balloon to dilate the artery. Often before we do that, we will use a device to clean the artery out. So this is a device that's called Jetstream, and it has little blades on it that allow us to cut plaque out of the artery, the blockages out of the artery. There are lots of these different devices on the market, and which one you pick depends on what the plaque, we call it the morphology, but the makeup of the plaque. And then occasionally,
and Mike,
yes.
Sorry to interrupt, but there's some questions
Absolutely.
here. That's called atherectomy, right?
Correct. Right.
And then angioplasty is the ballooning.
Right. Angioplasty ballooning, atherectomy is the cutting or removal or the sanding of plaque. In times where occasionally, sometimes we need to put stents in, this is a large stent. This is a venous stent that goes in veins, but the artery stents are very similar. These stents come in many different flavors. Sometimes we use stents like this that are covered with Gore-Tex, literally Gore-Tex, the same stuff that's on your jacket. We have different ways of deploying these stents. So this is a device as it's partly coming out of the delivery system. And so some of these stents come out like this. Sometimes the stents are mounted on balloons and we deploy them that way. Some of the devices, this is what we call an inflation device that we use to blow up the balloon. So it allows us to control the pressure in the balloon precisely. It has a gauge on it that allows controlled inflation of the balloons. So we don't overdilate them or don't underdilate them.
Mike, can you speak for a second to the access of how do all of these things get inside of you? So maybe just describe the sheath.
That's exactly where I was headed next. So everything sort of starts, the basics here are we get into the artery with a needle, and then through the middle of the needle goes this guide wire, and then this is called a sheath. And this is basically, this goes in and you can see this wire would be in place, and then we would guide the sheath over the wire into the artery. So you can see how this looks here. This allows us to get the sheath in, and then the middle of the sheath comes out, and then we have this hole that we can work through, and that's where everything gets guided in and out of the patient during the procedure.
And do you want to talk about the different access sites? I'm thinking radial, femoral, tibial.
Right. So that's something that we've seen a lot of change over the last sort of 10 years. The traditional way was everything we did went in through the groin, and now we have lots of different options. And so we can come from the radial artery, which is here, the femoral artery is here, and then also the arteries down into your ankle, and then a few other creative solutions beyond that. But our primary use, at least in my lab, is either something around the ankle or something in the groin. Often for doing work in the legs, coming from the arm is a little difficult because of the distance we have to travel. So primarily we're down in the groin and foot, sometimes the arm when required.
And Mike, do you want to, we have 5 minutes here, other questions. The patient's on the table and moving around. Why are they moving around so much?
Well, most people move around because it hurts being on this table. The mattress isn't great. And I think one of the biggest things that we do, or many people have done wrong, is there's this misperception that everybody needs to lay flat. And that's just not the case. And because most of us, as we get older, our backs hurt, in particular on these tables. So I think the most important thing is making sure the patient's comfortable. And so it may be a little inconvenient for me, but I like to wedge anybody up that has any back pain. And then that reduces our needs for sedation medications and to keep people more comfortable. So people move around because it's uncomfortable. Some people truly have restless legs or other neuropathic issues why they move, but it's discomfort and trying to keep people comfortable.
I guess I also meant how we're moving them on the table, right? So we're moving the table and they're kind of being.
Yeah, so we've got these fancy, we have table controls here, and I'll switch the camera so you can see our C-arm a little better here. So this arm is around you, and it moves in all sorts of different directions, back and forth. And then the table itself floats. So we have a mushroom that we can control and release the table as we pan around the patient. And then additionally, the C-arm will translate back and forth across the room. So we have lots of different ways of moving the patient around and seeing where we need to see, because we're moving often from the belly button down to the toes. So we have to have that huge range of motion.
And question, which I actually was going to address, and this smart group is already ahead of me. Closure devices, when do you decide to use them, and what does it mean for recovery?
Yeah, so there are a lot of different closure devices. You know, the two things we always worry about is how are we going to get in and how are we going to get out and do it safely. So we have devices that we can seal the holes in the groins shut. There are a lot of different techniques and devices on the market, and it really comes down to sort of operator preference and also what the artery looks like. When we're down around the ankle, we can use different sort of bands that will hold pressure on the artery once we're done. The closure devices are really nice because it allows you to raise people's head up much quicker or immediately after placement, so you're not laying flat for 6 hours, which people hear and it really frightens them. That's just not required anymore. And then when you're down around the ankle, it really allows you, you know, after an hour of just with the pressure band, you can be up and moving around. So the closure devices really make things easier for the patient, reduce the amount of time that you're in our clinic. So, you know, you can come in and get in from start to finish, get a very sophisticated procedure done, and yet only be here for 4 hours. So it's really nice for the patient.
Can you speak to a little bit to your facility and an OBL versus a hospital, maybe all the different sites of care?
Right, yeah. So I'm in what we call an office-based lab or an office interventional suite. So we're a freestanding center with a 7,000 square foot facility. Some of these centers you'll find in shopping malls next to a subway. Others you'll find, like ours, we're in an entirely medical building. The beauty of being out in an office-based lab, particularly for patients, is you know everybody in your clinic. You know, I have 15 employees. So when you have that longitudinal care, you see the same people. You're not getting lost going from one area to another. And I think the other really nice thing is that means, you know, a typical patient visit here, you're getting touched by 5 or 6 people versus in a hospital environment, you're getting 20, 25 different touches from different people through your visit. So you don't have that longitudinal care. Whereas here, the nurse that checks you in is the nurse that checks you out. And there may be other people involved along that way, but you're not constantly just getting dumped from one area to the next area to the next area. So that's some of the things I really love about not being in the hospital. The other side of care that we talk about is the surgery center, which is essentially what we're like. We're so, you know, even though we're classified as a physician office, we still function like an ambulatory surgery center.
Yeah,
Thank you so much. Yeah, that's amazing.
Can I say one final thing about that? Sorry, I always have so much to say. It's really the equipment. So what people have to understand is that the reason these centers are all in hospitals is because the equipment that Mike is standing behind is very, very, very expensive. So you won't find it in your average office. So when you say when you're going to a hospital thinking I need to be in a hospital for X, Y, or Z, that's not the case. It's just that's where you can find this equipment that Mike has behind him. So that's an important distinction.
I think that that's really important because there are some, various members in our groups that may have never been treated in an office-based lab and don't understand that it's really about, each individual patient, what their individual needs are, maybe what their other comorbidities are as to whether they might need to be in a hospital or could actually be in an office-based lab. And the benefit of being in an office-based lab is there is incentive to get you in and out that day as safely as possible. I mean, all doctors like to do that, but particularly in an office-based lab, you will be going home that day.